now.
All right, well, good day, everyone. This is going to be the first of a two-part series on dermatology and pregnancy. The first part is going to focus on specific dermatoses of pregnancy. And the second part is going to be more just a general overview of dermatology, just things that have nothing specifically to do with pregnancy, but which can obviously be seen in any pregnant patient. And I always like to begin this talk by just the observation that of all the organ systems that we are asked to evaluate as a physician, none is more readily available to our discernment than the skin. Yet often I find it's one of the things we seem to know the least about or we're the least comfortable with. I have very talented residents who can manage an incredibly complex medical case. But if I ask them to go in and see a rash with me, they panic. So hopefully this will help to some degree. Now, the other observation I will make is of these 4 dermatoses of pregnancy, we're going to omit the last one, which is intrahepatic cholestasis. So it actually has very few dermatologic findings, and it's really not a skin condition. It does sometimes display jaundice, but otherwise it really doesn't fit with these other 3. So we're just going to focus on these first 3. These are the most important ones. And there's this general observation that I've made that if you ever get to a point where you've run out of things to say in medicine, then just come up with a new categorization scheme for things. And so this is what's happened about 10 years ago. I think mainly in England, they decided to come up with these 3 new categories. So for example, what used to be called herpes gestationis is now called pemphigoid gestationis. So just a name change, a new nomenclature. But I will say that if you look at this table, there is some simplicity that's being gained by reducing multiple labels down to single labels. So I think that's its advantage. So next slide. First, we'll talk about the least common of these 3, pemphigoid gestationis. It's only found in about 1 out of 50,000 pregnancies. So maybe in my 25 to 30 years of practice, maybe I've seen 5 cases. It's very rare. It most commonly presents in the 6th and 7th month of pregnancy, though it does have a range of from 9 weeks to 1 week postpartum. But really seems to be right there at about the beginning of the 3rd trimester. It does recur frequently in subsequent pregnancies, which makes it a little bit unique. And if it does recur, it has a tendency to start earlier and to have more severe symptoms. So here's just a typical picture. It has this periumbilical distribution, which is very common, and it actually can involve the umbilicus itself. And then I find bullous lesions of any type are really characteristic and help you confirm the diagnosis. Next slide. So here, just this sort of, these fluid-filled bully or blister-like formations are characteristic. Next slide. The etiology seems to be related to circulating immunoglobulins that are directed against the bullous pemphigoid antigen, which is located in the basement membrane of the skin. The primary site of autoimmunity seems to be the placenta, as we've found antibodies bind to both the chorionic and amniotic epithelia. And on the right, you see some antibody profiles of an index pregnancy patient, the patient with bullous pemphigoid, and then a normal control. So you can see they have in common these antibodies directed against this skin antigen. So the lesions that you see are characterized by intensely pruritic, meaning very itchy eruptions of erythematous papules, plaques, and vesicular bullous lesions. It usually starts around the umbilicus, then it spreads to the trunk and extremities, including palms and soles. Usually the face and the mucous membranes are spared. As I said, second and third trimesters are most common. It rarely may present postpartum, but postpartum flares are extremely common. So after delivery, the patient's rash blossoms out, represents, even if they were well controlled. And then about 1 in 4 patients can have recurrences with birth control pills or during menstrual cycles. Next slide. So again, around the umbilicus, spreading to extremities with bully formations. To make the diagnosis for sure, you need to do a skin biopsy, and you're going to stain for immunofluorescence of complement and immunoglobulin along the basement membrane. You can measure what are called serum levels of anti-BP180 antibodies. These correlate with disease severity and help monitor a patient's response to treatment. But quite honestly, I don't think you need to do that, because you can measure their response to treatment just based on their symptomatology and how their rash is improving. This condition is associated with a newborn rash secondary to passive transfer of maternal antibodies, seen in about 5% of newborns. It can look quite striking, but it will resolve without treatment and usually in about 2 weeks. This condition is the one that is associated with fetal effects besides a rash. There's an increased finding of fetal growth restriction and also of preterm delivery. It's sort of unclear whether stillbirths are increased. Some series say yes, others no. So it's not clear whether fetal monitoring is mandatory or helpful. Next slide. That's just an example of how striking the newborn rash can be. It's also associated with other autoimmune diseases such as Graves' disease and vitiligo. Treatment often will start with topical steroids. I find they're usually terribly inadequate, and so you wind up using oral steroids, usually in a fairly high dose, and then you decrease the dose to the lowest dose that will control their symptoms. And you usually will treat them in the postpartum period for 8 to 10 weeks, because this is when flares are very common. You can also use oral antihistamines in addition to steroids to help the patient deal with their itching. Just late in the disease presentation, you'll get sort of confluence of the individual vesicles. Next slide. But again, just the bully formation is what's characteristic and can help you distinguish this from other dermatoses of pregnancy. Next slide. Here's an example of just a gross specimen under microscopy, and then you see the immunofluorescence staining to complement 3 along the basement membrane. That's the hallmark of making the diagnosis. So next we'll just talk about polymorphic eruption of pregnancy. You've heard of this in the past, referred to as PUP, or pruritic urticarial papules and plaques of pregnancy. It's the same condition, just with a new name. This is far more common, seen in 1 out of 160 to 300 pregnancies. 3/4 of cases are going to present in prima gravidas, and that can help you make the diagnosis. Generally, it's considered non-recurrent. About 1 in 4 cases are seen in multigravidas. It again also characteristically will present usually late in the 3rd trimester. The 39th week is actually the most common. Here again, just like PG, it tends to start around the umbilicus and then spread to the extremities. Next slide. The etiology is unclear. It's thought possibly to be due to skin stretching, as it is more common in twin pregnancies where the abdomen undergoes more physical stretching. Possibly an immune response to circulating fetal antigens, as it's seen in more male fetus pregnancies. Usually occurs in nulliparous women late in the third trimester, and rare reports of first or second trimester or postpartum disease have been reported. Here you see it. This is a good example of how it often will present in so-called stretch marks, and maybe this is related to antigens being exposed, but that's a common presentation. But then it becomes more confluent on the extremities, and then two more pictures kind of showing its predilection for stretch marks. So lesions appear on the abdomen first, often in stria. This is known as the Kebner phenomenon, which is just the tendency for a rash to appear in an area of trauma. Then it will spread to arms, legs, breasts, buttocks, the back. Face, palms, and soles are usually spared, which is another thing which will help you distinguish it from PG. Now, it's interesting that the itching of this condition is intense, but patients don't seem to scratch as much as they do with other forms of dermatoses. The eruptions generally last 4 to 6 weeks and will resolve within 2 weeks of delivery. The diagnosis here is largely clinical. You can do a skin biopsy, but it's really only going to show sort of general, not specific findings. Newborns are not affected. There's no increase in perinatal morbidity or mortality. Again, you initially try to treat it topically, systemic steroids for topical failures, and again, liberal use of antihistamines to help with itching. And then lastly, we'll just talk about atopic eruption of pregnancy. This is actually the most common of the three and comprises about 50% of cases. It's benign, self-limited, itchy disorder of pregnancy, usually associated with a personal and or a family history of atopy, so seasonal rhinitis, asthma, or atopic dermatitis. The etiology is thought to be related to immune changes of pregnancy, specifically changes in T helper cell cytokines, which lead to eczema. When you look at these cases, about 2/3 of them fall into the category of eczema and a third prurigo. So sort of a large scaly plaque versus a papule, an itchy bump. Next slide. There's just an example of sort of the prurigo form. Next slide. Lesions here can be found on the face, which is different, neck, breast cleavage, flexor surfaces, which are typical atopy areas. Diagnosis is usually clinical in a patient with a personal or family history of atopy. Skin biopsies are usually not helpful. You would only biopsy if you were suspicious that the patient might have PG. Treatment, moisturizers, which are creams or ointments, occasionally stop topical steroids, oral steroids for failures, and antihistamines can be tried. No adverse effects on the fetus, usually resolves either prior to delivery or within 2 weeks postpartum, and this one definitely may recur in a subsequent pregnancy. So there's just more of the plaque-like eczema manifestation. Next slide. And then on the right, more of the prurigo itchy bump form. And then just in closing, sort of a graphic comparison of the three different dermatoses. So if you see it in a primus paris patient, then you would think of the polymorphic eruption. If they've had identical skin lesions in a previous pregnancy, it's probably atopy. If it's presenting really early, it's probably atopy. If you see it in a subsequent pregnancy, then it could either be PG or atopy. If it tends to present periumbilical, then think PG or polymorphic eruption. And then again, as we said, the only one that really carries any concern for the fetus is the PG dermatoses. And I believe that's the end. This is the skin we hope all our patients have.